Hello everyone, myself Dr. Tarun Vyas, Leader Department of Oral Medicine and Radiology, College of Dental Science, Amargarh. I am taking on the topic diseases of blood. Now, first I will take the content of my topic, that is introductions. That is blood, component, plasma, red blood cell, erythrocyte, choices, hemoglobin, EBU, blood cells, disorder of blood cells, white blood cells. That is under which I will cover all the topics. Disorder of white blood cells. First, introductions. Introductions, that is what is hematology. Also spells as the hematology from the Greek word hema, that is blood. It is the branch of biology that is concerned with the study of blood or the blood cells forming the organ and the blood diseases. Now, this is the structures of the white blood cells, and that is the blood vessels that were red blood cells or the platelets, which we are showing in this. That is the compositions of the blood. What is the content? That is the erythrocyte, that is RBC, leukocytes, WBCs, neutrophils, that is about 60 to 70%. Eosinophils, that is about 2 to 4%. That is basophils, about 1 to 5%. Monocytes, that is about 3 to 8% that is present. And lymphocytes, that is about 20 to 25%. Thrombocytes, that is about platelets, and the plasma contents. That is shown to be at 55% about white blood cells, that is about less than 1%, red blood cells about more than 45% that is showing. And normal values that mostly you have to remember that the hemoglobins in the normals and the males report 13 to 18%. It's a range about that is deciliters, and 11.5 to 16.5 hemoglobin is 0.4 to about 0.5 to about 0.36 to 0.47, and different variable that is WBC is about 4.0 to 11, that is 101 patterns. And neutrophils we have a 2.0 7.5 multiplied by 1.09 per, and there are different values that we have to be known, and each of is 0.04, 0.41 multiplied by 1.09 slash liters. Platelets we show 150 to 400 range, and this is serum B12 we should be known, that is 150 to 700 nanoliters about per liter we should be. Then the classification of hematological disorder, that is qualitative disorders. It is cell affected and the disorder, that is Chinsky syndromes, and RBC enzyme deficiency, GP dehydrogenase deficiency, and pyruvate kinase deficiencies. Sickle cell anemia and abnormal shape, that is hereditary spirocytes and hereditary ellipsocytosis. Now, quantitative defects, that is the WBCs, increase in the number, that is the leukocytosis, leukopenia, and lymphomas, and the decrease in the number, that is agranulocytosis, that is cyclic neutropenia, and RBC, that is the increase in the number, that is the polycythemia, and the decrease in the number, that is the anemia, sickle cell anemia, and that is anemia, that is the thalassemia and the anemia due to the deficiency of the vitamin B12, folic acids, and the iron. And what is the applied aspects of the RBCs? That is the variations of RBC, that is in the shapes, size, and the numbers. And what is the variations in the RBCs? That is the crenation in that is a shrinkage, that is hypertonic solutions that you see, that is the RBCs of the normal shape. If it united shape, if you see, are told crenation, that is shrinkage. If it shrinkage, it is crenation. That is spirocytosis, globular hypertonic solutions. Elliptocytosis, that is elliptical, it will make elliptical in shape. Certain anemias we will see. In sickle cell anemia, cystonic shape, that is sickle cell in male form, but there is a variation in RBC shapes. You will see these shapes. Cystonic shape, it will crystallized in its shapes. And variation in RBCs size, that is macrocytes, anisotosis, iron deficiency anemia, macrocytosis, megaloblastic anemia, anisotosis, pernicious anemia. Variation in RBC counts, that is increase in count, that is physiological polycythemia, that is we will have a difference in age, sex, high altitude, muscular exercise. Decrease in count, it is high barometric pressures. We will have a different variation. Pathological variation, we have a, when you talk about this, that is a decrease in number, you will always have a anemia. When it increase in number, that is polycythemia vera, anemia. It is a very important definitions. An abnormal reduction in number of circulating red blood cells, the quantity of hemoglobin and volume of red blood cells in a given unit of blood in accordance to the age and the sex. Now, etiological classification: blood loss, acute post-hemorrhage, chronic blood loss, deficiency of post-hematological factor, that is iron deficiency, anemia, folate and vitamin B12, protein deficiency, bone marrow aplasia, that is aplastic anemia, pure red blood aplasia. It is anemia due to systemic infection, due to chronic infection, due to chronic renal disease, chronic liver diseases, endocrine diseases, anemia due to bone marrow infiltration, that is leukemia, lymphoma, myofibrosis, multiple myeloma, congenital sideroblastic anemia, anemia due to increased red cell destruction, that is intracorpuscular defect, that is extracorpuscular defects. Then there is a morphological classification, which is microcystic hypochromatic. If you see, it is micro hypochromatic. It is in iron deficiency anemia. Even when we go to normocytic cystic normochromic, then it will be a normal. When we will go to the macrocytic normochromic, we will then be with vitamin B12 deficiency anemia. Anemia owing to the blood loss, iron deficiency anemia, and Plummer-Vinson syndrome. It is very important when we are talking to the iron deficiency anemia and when we are talking to the Plummer-Vinson syndrome. And it is a type of syndrome. Plummer-Vinson syndrome is a type of trait. So when we are talking to the syndrome, it is a type of trait. Iron deficiency anemia is a reduction of the total body iron to an extent that iron stored to a fully exhausted and some degree of an iron deficiency present. What are the symptoms? That is chronic fatigue, pallid lips, oral mucosa, brittle nails, and spooning and cracking and splitting in the nails. If you see the patients having the brittle nails and spooling and the palmars and the seizes, the palpitation, sorting of the breath and the numbness and the tingling of the toes and the bone pain is there. And what are the oral manifestations then in the mouth? That is glossitis, stomatitis, angular cheilitis, recurrent apoptosis stomatitis, burning mouth is there, and oral candidiasis if you are seeing here. Now, what are the treatment modalities we are finding? 325 mg, see that is 60 mg of iron, orally 3 times a day. That is parasulfate we are giving, or iron dextran, that is parenterally no longer first line of treatment, can cause serious anaphylactic reactions. We will not. And oral health consultation, physician when we are consultation prior, when HB level more than 8 gram per deciliter, avoid general anesthesia, slow wound healing, and bleeding will be there. Severe anemia is there, then increased risk to the ischemic heart disease will be there. Then what is pernicious anemia? Autoimmune disorder, atopic gastritis will be there. There is a loss of parietal cells in the gastric mucosa, and there is a loss of intrinsic factor production. Then there will be the vitamin B12 malabsorption. What are the clinical features for this? Then there will be neurological abnormalities occur with the low level of vitamin B12. Then if you see these cases, there will be the vitamin B12 deficiency, neurological neuropathy will be there, polyneuropathy will be there, symmetrical paresthesia in finger and toes will be there. What are there? There will be the glossitis. If you see the tongues, we will have a hunter glossitis, angular cheilitis will be there. Investigation, hematological findings, serum bilirubin will be the raised, bone marrow we will finding. Normally the level of vitamin B12 will be raised, serum vitamin B12 radioisotope we will see in this level, normal high. Folate will be the higher in this. Red folate is normally sometimes reduced. Owing the folate synthesis, use screen test treatment. What are the treatment for this? Hydroxychloroquine, 1000 mg to the 5 to 6 mg over the course of 3 weeks. 1000 mg is the necessary for every 3 months for the rest of the patient life. We will give in the pernicious anemia or in this treatment plan, or for the hunter glossitis also. Now, what is the aplastic anemia? Pancocytomia with a hypocellulitis of the bone marrow. Can be inherent or the acquired. Now, it can be causes due to the congenital, that is, or it can be idiopathic. Secondly, that is, it could be the chemical or due to the drug, that is chemotherapeutic, or insecticides due to the ionizing radiation, due to the infections, due to the viral or perfusion, or due to the miscellaneous, that is through the pregnancy also. Now, what are the clinical features? That is, clinical feature can be due to anemia, the infection, that is leukopenia, that is weakness, that is the pallor, numbness to the tingling, that is the fatigue, there is the small dots in this, there is the thrombocytopenia, that is the purpuric spots, spontaneous gingival hemorrhage, ulceration in the oral mucosa. What is the radiographic appearance? What we got, that is the abnormal trabecular patterns. If you see this aplastic anemia, we will got a abnormal trabecular patterns will be fine. Investigation, prolonged bleeding time will be there, normal bleeding time will be there, but one of the most important is bleeding time will be prolonged. Next is the treatment part. Supportive care we will take broader spectrum time. We will take now severe anaplastic bone marrow transplantation. We have to do in this. A bad prognostic of the severe aplastic anemia is associated with the presence of 2-year follow-up. Sometimes we have to do it in this. Paroxysmal nocturnal hemoglobinemia. Paroxysmal hemoglobinemia is an uncommon complement mediator with the intravascular hemolytic anemia that results in the clonal expansion of hematopoietic stem cells, somatic mutation of X-linked terminus PIGA. It will lead to the free hemoglobin, lead to the fatigue, pain, eosinophilic spasm, erectile dysfunctions, thrombosis. That leads to the what we will do in this eclosion therapy. Now, what is sickle cell anemia? Sickle cell anemia is known as chronic hemolytic anemia. It will mainly in the non-6-linked characteristic occur in the black, white, Mediterranean origin, characterized by the hemophilic gene mutation and consisting of the replacement of amino acid, glutamic acid, so that valine is coded instead of the 6th position of beta hemoglobin chain. Now, RBC is mainly sickle cell here with the plasticity of the lifetime. If you see here, it is the normal red blood cells. Now here the cells become sickle cell. If you see, normal cells are normally red blood cells are formed, but here the cells become sickle cells. Now, due to the milder period, the patient may become fatigued, weakened, shortness of breath, muscles, and there will be joint pain in this. Heart become enlarged, systolic murmurs will be there, heart having the issues. Patient have become normal lifespan, about 40 years it will be there. Patient sickle cell crisis due to the administration of the general anesthesia, decreased oxygenation of bloods due to the heart problem, infection of pregnancy can lead to the circulatory collapse will be there in the pregnancy cases. What are the oral manifestation? If you see the patient with the oral manifestation, there is a delayed eruption, there is the Denathi, that is the maxillary access and the protrusion of the maxillary alveolar ridge, decreased overjet, interruption of the blood supply can result to the anesthesia of the inferior alveolar, pulpal necrosis will be there. Otherwise, sound premolar and molar to susceptibility of the osteomyelitis will be there. Now, if you see the same thing, this is the sickle cell anemia pictures. Now, what is the treatment for this? Transfusion therapy. Management of the pain, symptomatic treatment we will give. For this folic acid, again we will give the treatment, and the deficiency of the rapid proliferative marrow. Now, dental consideration for this prevent trauma, hypoxia. If hemoglobin concentration at least 7 mg DL to ensure the adequate oxygen delivery for general anesthesia dental procedure. Now, what is thalassemia? We can call thalassemia as a Cooley's anemia, Mediterranean disease, or erythroblastic anemia. Now, what is this? Heterogeneous group of characteristic disturbance in the synthesis of alpha or beta globulin chain. What is autosomal dominant rates or exhibit a racial patterns? What is alpha thalassemia? It can be divided into alpha thalassemia, that is deficiency of alpha genes. What is beta thalassemia? Deficient of beta genes. Excessive of the production of alpha damages to the erythrocyte, increased vulnerability to the destructions. Now, thalassemia minor rate, that is heterogeneous disease, minor and to the homogeneous, that is the homogeneous exhibits severe of the disease. Two forms, that is the mild to the patients to lead to the normal life. Hemoglobin Barr disease to the heterotrophs fetal, that is to the infants to the stillborns or die after the birth. Now, what are the clinical features? It mainly found in the childhood, yellowish, that is the if you see in the 12 to 13 years or 12 to 14 years, fever, chills, myalgia, and weakness, we will see splenomegaly, hepatomegaly, production of abdomen will be there, mongoloid features of prominence of cheekbone will be there, flattening of the anterior, depression of nasal ridges of the premaxilla, chimpic face will be there, and the depression of cephalofacial deformity is closely related. If you see here also, it will find in the children prominent cheek bone of the protrusive premaxilla, like rodent-like face. You see, like rodent-like face is there. Unusual prominence of the premaxilla is there. And hair and appearance of the skull, and same like inner and outer cortical plates defined in the trabecular between the elongated progeny hair and appearance as the same in the sickle cell anemia, but here the age difference is more in this. It comes sickle cell anemia, it goes to the 40 years, but here the age is about near to the children's. Widening of the medulla and thinning of the cortex or the long bone, coarsening of the trabecula and blurring and disappearance of the salt and peppering effect is also seen here. Jaw and skull long bone leading to the osteoporosis also here. Now, if you see, salt and pepper appearance is also seen more prominent here. Now, what are the management we are taking? Regular WRBC transfusion to avoid the death of the cardiac failure. We are taking allogenic hematogenic stem cell transplant cure the severely affected patient who both alpha and beta thalassemia. Folic acid again supplementation we are giving. Dental concentration patient with splenectomy at the risk of bacteremia. So patient receive prophylactic antibacterial oral penicillin, erythromycin before dental treatment. Now, what is polycythemia vera? Chronic myeloproliferative disease characterized at a prominent proliferation of erythro cell line at the primary bone marrow dysfunction that result in hemorrhage, thrombocysis, and increase in the RBC mass known as polycythemia vera. Now, there are the different blood types. I will not more deep, not go into the deep type. Blood types. Blood types that is referred to the antigen A, B, Rh, the most antigen. The term agglutinin is the most described antibody dissolved into that the specific blood group antigen. That is antigen on the red blood cell membrane characterized into the ABO blood groups. That is the A antigen, B antigen, and the Rh antigen. The type A is the A to the RBC, B is to the RBC, and AB to the A and B to the this, and O to the A and B to the RBC. Important principle is plasma never contain the antibodies and against the antigen present on its RBC, but plasma does not contain any antibodies against the A and the antigen D, and they does not have the RBC. This is the simple principle. Now, any transfusion principles against the great care take prevent a mixture to the agglutinations, and the agglutins, that is the it will result to the agglutinations of the donor and the recipient blood. That is the only things. Now, you have to remember only one thing: the type O blood group is considered to be the universal donor, as it does not contain the either antigen A and the or the antigen B. Type B is considered to the universal recipient, as it neither have the antigen A or the antigen B body. That is the AB positive, that is the AB negative. The RH system, the RH positive blood means RH system is present on the RH RBS, and RH negative means the blood, those who are the RBC on the RH, no RH antigen present on them. Then what is erythropoiesis fasciitis? Disease caused by mother Rh antibodies reacting to the baby Rh positive cells. Now, white blood cells, that is haldi polysaccharide. This is what classification according to this. I will give to this according to the presence and absence of the granules and the staining properties, that is the neutrophils, eosinophils, basophils, and the agranulocytes and the lymphocytes. That is the major thing. The classification are doing granulocytes and agranulocytes. These are the pictures. That is the neutrophils, eosinophils, basophils, monocytes, and the lymphocytes. This is the big picture that I was showing to you. That's the whole pictures. Now, what is the neutrophils? Neutrophils are the most abundant type of the accounting for the 75% of the WBCs. They have a very short lifespan. They circulate about blood about 6 to 7 hours. They migrate into the endothelial cells. They are called the neutrophils because they are the granules of the poorly with the mixtures of the dyes like staining leukocytes. Now, they are the neutrophils. They have connected about the 3 to 5 connected lobes. Hence, they are called the polymorphage leukocytes. Okay, like this. They are like neutrophils. If you see, they are connected by 3 to 4. If you see this thing, they are pink in color. So, killing strategies, battlefields, chemotaxis, recognize the enemies, eat with them. Phagocytosis. What is neutrophilia? Abnormal large number of neutrophils, pyogenic infections, causes osteomyelitis, abscess, peritonitis, burnout in post-operative states, acute myocardial infection, metabolic like diabetic ketoacidosis, poisoning with heavy metals. Eosinophils, large number stain orange, like 3 to 2 to 5% of WBCs, numerous respiratory or digestive tracts, weak phagocytis, and it is important to protect against the infection caused by parasitic wounds or allergic reactions. Now, what is eosinophilia? In the parasitic infections, as in filariasis, allergic condition like bronchial asthma, like in dental, like malignant tumor as Hodgkin's disease. Now, basophils have a relatively large but spare cytoplasmic granules like stained dark purple and basic dye. Like about we have content of 0.1% leukocyte counts, motile and capable diaphadesis. Exhibit S-shaped nuclei. Granules of these contain histamines and heparin and anticoagulants. If you see, monocytes have a round or kidney shaped with a fine granular cytoplasm measuring 12 to 15 or 3 days circulation. Monocytes normally have 2 to 5 of WBCs. Monocytes leave the circulation and entire tissue they cause macrophages. Now there are two types of macrophages. One that wanders into the tissues, and other they are fixed with the vascular endothelium into the liver, spleen, lymph nodes, and other tissues. Macrophages present in the different organs like histocytes, Kupffer cells, alveolar and peritoneal macrophages, and macroglial cells, mesogynial cells, and osteoclasts. Function of macrophages like killing the microbes, infected cells, secretion, immunomodulatorily, and macrophages responds to the infection quickly to persist for the longer, and hence they are dominant for the effectors to kill for the later stage of the infection also. Now, what are the agranulocytes? They are the lymphocytes, small of the leukocytosis, about 6 to 9 mm. They are spherical in shapes, very pale, limited amount of pale blue in staining. For 25% of RBCs, they are counting beta T lymphocytes. They are directly attacking of the infected and cancerous about production of antibodies against the specific antigens. You see this whole thinking, white blood cells disorders. Now we are taking white cell disorders classifications. Leukocytosis, leukopenia, leukemia, lymphoma, multiple myeloma. Now, what is agranulocytosis? Marked decrease in circulatory granulocytosis, that is neutrophil, that is neutropenia. It is divided into mild, moderate, and severe. If you have no neutrophils, we count into the agranulocytosis. What are the causes for this that I have briefly picturized into this? So bone marrow, stem cytosis, myelocytes, these are the mitosis differentiations are there, and then into the bands, neutrophils, and then the anti-cancer irradiations, then due to the genetics also tumors, leukopenia, osteoporosis, and due to the genetic irradiations, tumor, leukopenia, and osteoporosis. All are the causes for this bone marrow and all. And what are the clinical features for this? That is the brief I have thinking pictures, like bacterial infections are there, effective pharyngitis are there, the lymphadenopathies are there. What are the oral manifestations? That is the oral ulceration. If you see here, pictures I have shown for you, oral ulceration. Then after that, uh, uh, oral ulcerations. Then laboratory findings. WBC count will be reduced. DLC absolute decrease in the neutrophils. What are the divide of the neutrophils? What is the treatment for this? We will give simple infections reduced. That will give carbamazepine, gentamicin, WBC transfusions. Severe plastic and bone marrow transplantation we will do. Oral ulcer we will give pulpar infection, bacteremia, septicemia, or parental antibiotics. Pain we will topical anesthetics, mouth rinses. Oral we will give if thousands centimeters less than prior to dental extraction, reduce bacteremia infection. What is cyclic neutropenia? Sometimes an idiopathic disease in episodic defects in neutrophils mature in bone marrow and period decrease in neutrophils. A periodic fail in the stem cell bone marrow, that is known as the cyclic neutropenia. It lasts for 3 to 5 days. A frequency varies for 2 to 4 days, 2 to 4 weeks. Cyclic feature is fever, stomatitis, pharyngitis, and the skin abscess. This is known as the cyclic neutropenia, that is oral ulcer in the neutropenia, that is about the palate and the alveolar ridge. That is the periodontal abscess we will see, that is the alveolar bone loss, periodontal pockets. And we will see all the full mouth. We are a 4-year-old. I have taken this and the cyclic neutropenia and showing the resorptions with this and alveolar and supporting bone we are seeing. There is neutropenia, we are seeing the pictures. And what are this WBC count will we are seeing, and the decreasing infiltrate about the neutrophils are also there. What are treatment for that? Careful monitoring for the patient will we have to do it. Granulocytes stimulating factor we need it. And what is the infection mononucleosis? Next topic. And infection mononucleosis is the disease of the beta lymphocytes caused by EBV. That is the that caused by the marked mononuclear leukocytosis. That is also caused as kissing disease. This is also known as the kissing disease. Incubation period is 7 to 10 days. What is the clinical features? Fever, headache, chills, cough, nausea, vomiting, lymphadenopathy, splenomegaly, hepatitis, tonsillitis, pharyngitis. What is that? Palatal this is the patagy, that is small patches. Occasional ulcer is there. We will find gingivitis, stomatitis. Then the ESR raised is there, WBC raised are there, normal titer agglutinin is. Now, what is the treatment? Acyclovir we will have to give, that is the viral drugs we will give. Short-term steroid therapy we can give. Now, leukocytosis. What is leukocytosis? Versus leukemia. Sometimes we will discuss it. Leukemia first we will discuss. Applied to the group of the malignant cells characterized by the malignant transformation of the hemophytics that replace the normal cells. Any group of malignant cells that replace the malignant transformation to adult hemophytic cells. Leukemia cells eventually lead to the bone marrow and infiltrate the lymph nodes, liver, spleens, and the body cells. Type of leukemia are the acute lymphocyte leukemia, acute myelocyte leukemia, chronic myeloid leukemia. I'm again repeating leukemia because it's important. That is myelocyte, malignant transformations of the adult hemocytic cells to the replacement of the normal cells. As you see this, abnormal proliferation of bone marrow to the normal bone marrow. Here also you see Etiology, that is ionizing radiations, cytotoxic drugs, retrovirus, genetic, immunology, lymphocytic, myelocytic leukemia. Cancer can either due to the lymphocytic, that is myeloid, that is when the cancer develops due to the lymphocytic, that is lympho, it called, that is the lymphocytic leukemia. Cancer developed due to the granulocytic, that is the myelogenous leukemia. Acute and the chronic. The number, the new and the immature and called the blasts remain very immature and cannot perform their functions. The blasts increase in number rapidly and the disease progress very quickly. It is known as acute leukemia. And there are some blast cells present, but they are more maturely and are able to perform some of their functions, and the cells close more slowly and the numbers increase less quickly and so the decrease gradually. Leukemia are classified into the acute myelogenous, that is AML, chronic myelogenous leukemia, acute lymphocytic leukemia, chronic lymphocytic leukemia, that is old age, anemia and its symptoms, that is we will see it, that is pain, skin, fatigue, bleeding, brushing, loss of appetite, swollen tendons, lymph nodes, live, and fatigue, swelling, bleeding, and sweating is there, joint pain. But what are the symptoms of leukemia? Headache, vomiting, confusion, muscle, joint pain, seizures, swollen testicles, sores. If you are seeing eye, what are the chronic leukemia symptoms? We are seeing in the skin, central nervous system, digestive tracts, and in the testicle. Like if you see in the whole, common symptoms like there will be weight loss, fever, frequent infection, shortness of breath, weakness, pain, fatigue, loss of appetite, swelling is there, enlargement is there, night sweat is there, purplish patches is there. While we're finding, what is the oral manifestation? Pallor of mucosa, fatigue is there, ecchymosis is there. We will see in ectotoma, hematoma of the tongue. We are finding in this. Now, gingival bleeding is there, oral ulceration is there, candidiasis sometimes we are finding in this oral ulceration, myeloid in the leukemia, we are finding gingival hyperplasia, boggy dumb bleeding is there, teeth become mobile, destruction of lamina dura, displacement of lung. No, after that, physical examination for swelling and the liver, we are doing some blood tests for this, and lymph node biopsy we can do, and some imaging procedure like X-ray, ultrasound, and CT we can do for this, and liver, spleen, lymph nodes, and growing, and we can do blood tests in laboratory. Treatment, what we can do? Chemotherapy, radiotherapy, and red blood cell transfusion we can do for that. Preventive oral care, what are the treatment for that? We can do RCT, we can do topical fluoride applications, we can do antibiotic prophylaxis, physical consultation, we can do control measures, platelet count, sometimes we can do physical consultations, can antibiotic coverage, manage oral ulcerations, analgesic, we can go bleeding, we can absorption gelatin, we can do. Now, what is lymphoma? About lymphoma, that is a malignant tumors involving the lymphoreticular immune system, that is beta lymphocyte, T lymphocyte, monocytes. Etiological unknowns. Risk factors are immunodeficiency states, that is the viral infections, that is the chemical exposure. And the classifications are Hodgkin lymphoma, non-Hodgkin lymphoma. What is the difference between Hodgkin and non-Hodgkin? That is localized to the axial lymph nodes. Non-Hodgkin lymphoma means multiple peripheral lymph nodes. That is the contiguous spread in Hodgkin. It is the non-contiguous spread. Mesenteric, wildly rare ring is involved, not there in Hodgkin, but non-Hodgkin we are finding the wildly ring involvement. Extranodal involvement is there in the Hodgkin, while there is the extranodal involvement is always there. No oral manifestation we are finding here, but oral manifestation are always found in the non-Hodgkin lymphoma. So there are a lot of findings like Pelletier being there in non-Hodgkin lymphoma, like extranodal involvement is there. There are, but in a Hodgkin lymphoma we are finding contiguous spot, that is the localized to the axial lymph nodes, but multiple peripheral lymph nodes we are finding in non-Hodgkin lymphoma. like Hodgkin lymphoma, Hodgkin lymphoma, a malignant tumors like lymph node, like red string blood cells. Now, classification of Hodgkin lymphoma, that is the lymphoid predominance, nodular sclerosis, and the mixed cellularity we are finding. This is also the classification which we are about the 5-year survival rate on the basis of this lymphoid depletions. Staging of Hodgkin lymphoma, involvement of one lymph node to the single extranodal nodes. Staging 2, involvement of multiple lymph nodes to the region of the same diaphragm, involvement of the lymph node on both sides of the diaphragm, generalized involvement. Subclassification, we can take no symptoms, fever, nights, about 10 marks. Now, what are the clinical features? We can take PELS, abstent virus, and night sweats, hepatosplenomegaly, painless, rubbery, lymphadenopathy, cervical, axillary, inguinal. Now, what is the ESR is raised, chest radiograph, we can take lymphadenopathy, biopsy, we can take full mouth blood count, we can take normal. We can, what are the radiotherapy treatment we have? We can have we can do ABVT, that is adrenomycin, bleomycin, vinblastine, and dacramycin. We have a full viral drug we have to give in this. Then we can give a radiotherapy or chemotherapy in this. Now, what is the chemotherapy? We can have also this. That is the chloroborosin, vinblastine, procarbenzine, prednisolone. We can also give about this much of the dose. That is 6 mg, 6 mg, mmg, 100 mg. We can do about this much of regimen, about 6 to 8 cycles we have to give. For non-Hodgkin lymphoma is very important for, and most prominent that as compared to the Hodgkin lymphoma, it is most prominent found out. Lymph nodes organs and extranodal lymph nodes are found. Mainly arises due to the lymphocytes and immunosuppression and chromosomal abnormalities, environmental pesticides and herbicides, like slowly progressive and painless lymphadenopathy, fever, chills, night sweats, weight loss, and large abdominal mass like sphenomegaly, like maxillary sinus, nasal cavity, maxilla, growing nodular mass, deep ulceration, mobility of tooth, like extraction of nodes, subfluctuate swelling, ESR raised is raised, and like we can give vincristine, chemotherapy in this. But most important thing here in non-Hodgkin lymphoma is the maxillary sinus. We have to see maxilla, growing nodular mass, mobility of teeth, delayed healing of extraction, nerve invasion of paresthesia, heart, palate, swelling. We have to see bilaterally or single swelling. Is chest radial lymph node biopsy, that red stem cells, that we have both we have to see. But mobility, maxillary sinus, and treatment here is the cyclophosphamide, and that is oncovid, that is vincristine, prednisolone we have to give. That is the multiple myeloma is second important thing here. Malignant proliferation of the plasma cell, that is single heavy and light chain, that is the paraprotein. One light chain, that is the benchose proteins. Classification of multiple, that is IgG, IgA, light chain, and other DA protein. Equally to both sexes, that is 4, 5, 6, that is skeleton and boneless protein, that is pathological fracture, renal failure, and paraproteinemia, and bone marrow plasmacytosis are the indications. That is the, we have a lot of features, that is the skeleton pain, bone, and the renal failures. We have to be the findings. What are the oral manifestation here? That is multiple radiolucental, that is the mouth-eaten appearance in this feature, like skull bones. What is the radiolucental feature? Mobility of the tooth. Tooth become mobile, jaw swellings, and paresthesia and the growing tumors we are finding. Investigations, serum, urinary paraprotein, skeletons are there. Treatments, what is the chemotherapy? First, Mibals, radiotherapy, high fluid we have to take in the renal, because as the renal being affected to hypercalcemia, we have to take stem cell transplantation, biphosphatemia, bone pain, and apoptosis of malignant tumor, dental concentration. What we have to do? Anemia, infection, to hemorrhagic tendency to the renal failure, corticosteroid. Now, what is Burkitt lymphoma? Is the malignancy of Burkitt lymphoma origin from the representation of the differentiated lymphoma? It is EBV. As many of the 50 to 60, 70% of African Burkitt lymphoma of the malignancy usually affect from the children prevalence of the Central Africa. They are mainly found in this, not in the growing age, but about the 7 year of age, that is about the 7 to 8 or 10 to 12 years. The posterior segment of the jaw affected maxilla or mandible only, and sometimes of the fourth quadrant of the jaw of the tumor. The radiographic features of the malignant process, and that is the ill-defined margin, patchy loss of the tumor, that is Burkitt lymphoma. You see this picture. Burkitt lymphoma, that is the star's key appearance for the intersection of the cytoplasm. The treatment is the chemotherapeutic regimen, that is the cyclophosphomides, and more than 90% of the patients. What is hemophilia? That is actually disorder that affects the 1/1,000 patients. With the one more plasma protein responsible for blood clotting. What is thrombocytopenia? Condition is characterized by the bleeding for many blood vessels that is most visible to the mucous membrane. It is the catastrophic to the bleeding disorder, usually causes the bone marrow destruction of the drugs of an immune system and radiation and phosphorus. What's platelets? Properties are smaller nearly to that cause appear to the irregular spindles and overall 2 to 4 minutes deglutition, adhesive and adhesive overall. What is the function? That is the hemostasis, blooding and coagulation, and hemostasis and refer to the stoppage and blood flow and may occur and result to the several body defense organisms. Formation and lifespan for this is the characterized, and about lifespan is about 7 days, and it is about bizarre in space and multiple nuclei and fragmentation for the large cells and middle cells. What is clotting disorder? Clotting disorder means and clot sometimes when broken blood vessels and stay in place, and thrombus and condition means by the thrombosis. All parts of clot dislocates, it circulates throughout the vessel, and embolus and condition of the embolism. These are my references for this, and thank you for the patient listening.